Well, Stephen, welcome. I know you had a long flight. Really, thank you very much for actually coming here and gracing our symposium. So this is a case really right up your alley. This is a patient who I'm going to present in a second, but you haven't met our team. So to my left is Dr. Karthik Guja, who's our Associate Director of the Endovascular Program in the Cath Lab at Mount Sinai. To my right is Dr. Vishal Kapoor, who is the Director of Mount Sinai West in the Cath Lab for the Endovascular Program, or I'm sorry, Mount Sinai St. Luke's. And to the right of him is Ray Lascano, our interventional nurse practitioner. We have Ashley and Eitan, and I think that's it, right?
Yeah, Ernest.
Nobody else in the, Ernest is our technician. I didn't see him there. And Ernest is there as well. So we have a fantastic case that I just want to go over. I just want to tell you what I think we should do. We're going to demonstrate pedal access, and we're going to do probably the TAMI technique of intervention through the retrograde. And then, so after pedal access, I think you should go to the lectures and then keep us on the side and come back to us. So let me present the case. Slide, please. It's a case of critical limb ischemia with retrograde intervention through pedal access. Next. So the 72-year-old male, he's a hypertensive, type 2 diabetes. He's an ex-smoker with severe COPD and CKD. He basically had left leg pain for the last 3 months, which has now progressed to having an ulcer at both the plantar and the dorsal aspect of the right great toe, pretty much in the dorsalis pedis distribution. He had a resting ABI in wound care, which showed a resting ABI of 0.61 with calcified vessels, with really just a very calcified vessels by ultrasound. And they did an angiogram and an attempt at an outside facility. New York, as you know, probably like Singapore, a lot of facilities where patients are very migratory and go to different hospitals and then end up with you. So we had received the angiogram for them, which I'm going to play you. And basically, we took pictures here as well. Let me show you. So basically, this patient we got right access to a 4 French sheath just for visualization for everyone. We went up and over with just a pigtail catheter, and then we took an injection. And then you can see the SFA is quite good, the popliteal is quite good, and at the level of the anterior tibial, which is his only artery, there's a long segment occlusion with the posterior tibial also reconstituting distally and then fading out at the level of the ankle. So at this stage, we just took a closer picture. You can see that it's a calcified lesion here, and you can see the calcification of the anterior tibial. And then in this picture, which is the DSA shot, you can see again everything pretty much includes a focal high-grade narrowing of the proximal anterior tibial. And then in the mid-anterior tibial, this is the real calcified segment where they failed, and I think they got subintimal. You can see here that the anterior tibial comes, stops. You have some kind of islands or bridging collaterals, whatever it may be. Seems like a short segment, but a heavily calcified segment, which we'll show you on the fluoro. And distally, he's got a robust AT, which you could probably bypass to, but because of his COPD, really not a candidate for that. And also, I think that this is an issue here as well. With such a good vessel, we should be able to get through and from an endovascular perspective. Again, we didn't give too much dye. I just want to show you very quickly the actual calcification on fluoroscopy, and then we'll just move right out of the way. Can you come on this side, please? So you can see on fluoroscopy, you'll see the calcification very, very clearly. So we're going to go just LAO a little bit, and then you're going to see it. Watch your knees, guys. So you can see he's got a heavily calcified occlusion in this area. And I think this is the reason, because you have pretty much calcium obstructing the vessel. So before we get started, Dr. Guja is going to demonstrate pedal access, and then we're going to put in a sheath. Since they failed from above, we're going to try to do the whole intervention from below in that technique. Karthik?
So, hi, welcome everyone. So basically, like Vishal showed it in the previous case of how we look at the ultrasounds, we have a hockey stick high frequency probe here, which we use here in Sinai. And then as you look at the ultrasound, you can see every tibial artery has 2 tibial veins associated with it. That's the basic way of visualizing the artery. This artery is decent in size, so we can visualize it, but the arteries are small. If you want to visualize it, then you have to visualize it based on the veins. Like when you compress, you can see both the veins on the side getting compressed and the artery not compressible. So that's the marker. And you have some calcification on the artery. So we basically go, if you're getting the anterior tibial artery, you want to go at the level, just below the level of the ankle. And then we stick it. We find the needle tip, which is the most echogenic part, right? You find the needle tip, you go, and you write on the vessel You just enter the vessel. And we have the flow right here.
So once we have the flow, we're going to go to a longitudinal view. You want to fix it with your hand?
I will.
Yeah, let me
I will.
wire for it.
Okay, we're going to go to the longitudinal view, and we're going to show the wire go up. And what we're going to do here, Stephen, is we're going to go ahead and put the catheter, the actual Cook pedal sheet, the 3.9 centimeter sheet, excuse me, the 2.9 French sheet in, and then we're going to go ahead and do it. Is there any resistance?
Yeah.
No
No
resistance.
resistance.
So now that we have access with ultrasound, we're going to go ahead and put the sheath in. And the plan here, Stephen, is going to be to cross from below. Just to give you an idea of our plan on what we're going to do, we're going to use the Cook CXI 018 90 centimeter catheter. We're going to use the Command 018 wire, and then we're going to go ahead and use the Connect family of wires to cross this calcified lesion. If we're lucky enough to cross very quickly, plan will be the balloon angioplasty with the Cook 018 pedal system, and then do everything from the pedal and hopefully not bail out stent, but we'll see. So the issue with stenting is going to be an issue, and we'll address that if we need to get to it at that point.
Yeah, that's good.
So we're going to get started. You can get the panel up, maybe start the first
Very
lecture.
calcified,
And I welcome any thoughts or comments from you, Stephen, on our approach.
So PK, that was a great demonstration by a team on retrograde access to the anterior table under ultrasound guidance. I just wanted to get your, I'm joined here by Mehdi, who's returned, but I just wanted to get your opinion on what's the plan here. I mean, we have a calcified single vessel tibial. That's the by angiosome concept is supplying the first toe, and antegrade attempt has failed. So it's a retrograde approach to try to stay true lumen, and then maybe some vessel prep atherectomy of some sort. Is that the concept, or would you prefer a subintimal passage antegrade and then rendezvous? I mean, is there any benefit from staying true lumen in a calcified vessel? That's what I'm saying.
I mean, ideally we'd like to. My worry is that level of calcium, so I think that it's going to be difficult to say true luminal all the way through. We're going to try our best here. Sir, don't move. We're going to try our best here. You can see he's very sensitive.
I know.
Sorry about that. So what we're going to do is we're going to try to stay true luminal. If we get subintimal, then we're going to have to deal with stenting or not. So interestingly, I think that it's off-label, but we can use the new Zion Sierra through this Cook sheath because it's 4 French, guys? Compatible. And we actually have done that in the past. It's 2.7 French. 2.7 French compatible, and this is we actually put it through the sheet foot in cases like this. So I think ideally it would be good to be interluminal, cross through, and then work through the leg. If we can't, we'll come from above and do a rendezvous. So we're going to get started. Let me have the Cook CXI, guys.
PK, this is Mehdi. This is a great case, and it's nice to be able to do these cases now from the pedal approach. I think that now that we also have radial devices, you could potentially do the diagnostic angiogram via the radial approach and then treat the whole lesion via the foot. And the patient can go home in a couple hours. So if you need to do a diagnostic, if you're going to do everything from the foot, I guess that's one option. But if you need to do the angiogram from the top, you can do it from the radial and then just treat from the foot. I don't know if you are doing this these days or not. Radial pedal.
Actually, Mehdi, that's a great point. I mean, there's a radial craze going on in the coronary, and I don't want to be how can you say cavalier about using the foot for access point. I got to tell you, Mehdi, that you and I both know that the pedal vasculature is not at all similar to the radial hand vasculature. So you have to be very, very careful with these particular types of vessels, not to be cavalier. Push it up. Show me below, guys. So I think that in this case, the radial sheets will be very good. I know we've used we've used the slender sheet from the foot, but in this case we felt, go ahead, push it up. In this case, we felt that because we have this ability to stent in these complex lesions, this may be an issue. So we're going to keep going up, and we know the occlusion starts right about here. So now I'm going to switch out. I'm going to try with a hydrophilic wire. So give me a command hydrophilic wire, guys. The 014 command. In the field. So we're going to do it right now, and then we're going to see whether we're able to cross. What we've noticed, Mehdi and Stephen, you guys know, in these kind of lesions, when they have trouble crossing from above and they happen to dissect, you know, a lot of times you get access below and you just fly through. And I don't know, Mehdi, if you saw the film. I'm just going to play it again for you. It looks like that there are some islands, and I think the calcium is what caused the mechanism of failure here. You can see here this calcium. It's a short segment occlusion in a single vessel. It's a very robust vessel, as you can see distally, but there clearly is an area of a channel that we can find. So I'm just going to go with a command wire here, 014 now. And our plan here is to start with 014 systems and upgrade to 018 systems. So I'm going to use the calcium as my marker. And could I get a torquer here, guys, and a wet sponge? And I'm going to use, and mag up for me a little bit, please. And a lot of times you can just kind of fish through these micro channels using a 014 wire. See, this is going to be an issue. And I'm hope this is not going to be one of those times, I guess, huh? Let's see.
I'll hold it.
I'm going to take the CXI a little bit closer here.
Is it torque?
So, Mehdi, what's the choice of wires in this situation for the retrograde? Would you also use a command, a hydrophilic, or would you go for maybe a CTO, or what's your preference?
Yeah, I like his approach. You know, PK. You know, obviously, I think that he believes that there is maybe some kind of a track, and maybe it's a subtotal occlusion. Maybe there is a channel there. So using a jacketed wire, using hydrophilic jacketed wire in this situation, I think makes sense as a first approach. If you can find a channel, stay luminal, that's fantastic. If you need to do atherectomy, that will help you. And also, if you don't do atherectomy, you just want to do angioplasty, I think staying luminal, obviously we know is better. You don't create a dissection. If the hydrophilic wire doesn't work, which I think looks like, that's why PK said, oops, I think there is something here. I think that calcium is like a little rock. So unfortunately, that calcium may not allow us to get through it.
Yeah.
Right.
Yeah.
And in those situations, then you need to bring in maybe a CTO wire and try to see if you can kind of work your way through that calcium.
Yeah, I mean,
That's nice.
What do you
Take
think?
it.
I think great point. I would do exactly
you
what
can copy
PK
this
is
away?
doing, always with the hydrophilic jacketed wires. You know, but sometimes what I find is just basically pushing the support catheter straight up.
Yes.
You know, sometimes it helps to find
Yes.
the channel.
Right there, Stephen, I took your advice. We just pushed the CXI, which is a beautiful catheter for this kind of application. It really has a nice stiff ability to be able to push. And now I'm going to go with a wind wire, again sticking with the 014 systems, and then try to go up through this. I can ask Dr. Guja to give a little dive from above so you can see the reconstitution zone. And you know, we normally don't do this, but I just think it's worthwhile for the audience to see how we're progressing. And don't touch his ulcers, I'm in pain. Hold on. So let me see here.
Give me a torque.
Yep, torquer. So this is one of those where, as you can see, we're going to try to use a torquer to go up. Now we might have to do both sides, come from above and below, and sometimes these shorter lesions are the one. One of the problems I find is it's a little cumbersome in terms of lengths of everything from below and above. So that's also another issue here. So we'll see whether we can get into this channel somehow. Nope.
This is another reason why, Steve, I don't know what, Stephen, what your thoughts are, that I like to have access from the top, either via the groin or via the radial approach. Because, you know, if you're not able to cross, now you have given heparin. And now you want to get groin access. You know, I think PK did it the right way. He got access in the groin already. But if you start from the foot, give full dose heparin, anticoagulate the patient, and now you're not able to cross, you either have to bring the patient back or you have to access the patient in the groin with heparin unless you go radial approach.
Yeah, I fully agree, Mehdi. I'm always somewhat uncomfortable just going completely from the bottom. With an antegrade access early on, I think the risk of bleeding when you give a much lower. And I think it's good to do a control angiogram after you remove the retrograde sheath, because if you're thinking of doing everything retrograde, you know, I never like to leave the table with an angiogram of spasm unless I really have to. So that at least gives us an idea if we've caused any damage from the retrograde or whatsoever. You know. So PK, tell us, you looked like you made some progress.
I am probably 100% subintimal here, as you can see. You know, I'm just trying my best to get close, and I think maybe we might have to do a cart or a reverse cart and see what happens. You know, I've got an angle catheter here, and again, like you said, Stephen, I just, you know, sometimes you can't be that gentle. You just got to push up, and see where this goes, and this particular one right here, now it's going to an area which I don't like. So what I may do is advance my catheter a little bit and then try to torque it in this manner, or maybe come from above and below. I'm also going to change my tip. That also helps, as sometimes to change your tip, and then try the 018, the Terumo gold wire. That also is able to find some of these weird channels that work. But this wind wire is very slick. In our hands, we are very happy with it. It seems to work really, really well. And we're gonna. This is normal. I wouldn't get people excited about this. This is all subintimal stuff. Give me a little dive from above. I think I'm just dissecting up here, and this may be a cart case. Let's see. Yeah, not quite where I want to be. I'm going to try to change
That's
here.
the cap.
You pull back.
Yeah.
Don't move.
Try not to
Pull
move,
back a
sir.
little bit. That's it.
So maybe, Stephen, now while we struggle a little bit, you can go to a lecture and then come back
Nice.
to
I like
us.
that.
Yeah,
Give me a little dive.
Okay, well, that's a good idea. I think
like that
I'll
spot.
give the next lecture, and then Maddie's got one, but we've got plenty of time to stay with you, so we'll give you some time to do a bit of work first.
Okay,
Hi,
so
PK,
we made some progress, and we're at the distal cap, and we're unable to able to actually break that
need
distal
Terumo
cap. So we're now switching for an 018 Terumo wire
Terumo gold.
to show you where we are. So we had to pull out the CXI because we actually were pushing so hard, the CXI started to kink. So now we're going to go with an 018 wire with a new CXI to go ahead and try to get through. And this, I can see why they failed, guys. This is not an easy lesion. I mean, obviously, we might have to go above and below and come back to you at a
Flush
different
it, flush
time.
it,
But,
flush it. You have to
I
flush
want
it.
to see whether we can get through this.
Good.
So this is the nice Terumo wire. Stephen, what are the wires you like in Singapore? And do you have things that we don't have here in the States to break these type of lesions?
Well, I mean, obviously, I think you have a great variety of wires over here. In my lab, I tend to stay with the command wires, floppy wires, a few selected CTOs, but I think everybody's got your own preference for wires, but I haven't had the luxury of having too many wires in my lab. Maddie, you have...
Hold the wire.
I also, as I presented in the last presentation, I like to stick with 2-3 wires and become very comfortable with them. So for
Exactly.
jacketed wires, I use Pilot 200, and the Glide Gold, I think is a very good wire. But you have to be careful with it because it does find things. And for CTO wires, I usually use the 250T. Is the 018, 31 gram, wire. So those are really 3-4 wires that I usually use. If then I need something else, then I will find something off the shelf, one of the coronary wires or something.
It's interesting because all the wires that you are using are exactly the same that I'm using. We must be attending the same conferences. And
So you can see we're pretty much doing a retrograde dissection here, is what it looks like. And I keep dissecting up. So I'm going to try to reorient my catheter in a different manner and see if I can find another plane. If not, I think we're going to have to do a cart technique here and try to see whether we can get out. I don't think a hydrophilic wire is the answer here. I'm also going to maybe pull back below and try to get in between the calcium here and see whether we can pop in.
You try a CTO wire and try to get through that middle of that calcium, because looks like that's where you're getting into trouble. You're going...
I agree.
If you
Give me
can
the
somehow get in the
Astado
heart
21.
of that calcium and go through it.
Another startup.
Yep, I'm
You
going to
know.
go with the coronary Astado 20 here and try to get through. I'm going to ask Dr. Guja to come from above. So Dr. Guja, can you put a, see this is I think the kind of the difficult cases where you have to come from
Give me a
above and
command.
below. So I'm going to have Dr. Guja come from above so we can get ready to do a cart technique if we need to. But I still think we're going to plan on working from below. He's just going to use the 4 French catheter there as a support catheter,
regular.
and then come
Yes, give
through
me a
there with a wire and say an 018 quick cross, and then let's see whether we can meet our wires, do a cart technique, and then we'll work from below and finish this case. So this is the Astado 21 wire, and my next one I'm going to go to the 018
Give me a needle
Connect
introducer.
250T. Can you guys get me the Connect 250T, guys? And then we'll work here with
I
the
have it.
Connect.
I have it.
Show me down below, please. Okay. So I'm also going to just come way below and start again, trying to
there
get a
is
new
perfect.
plane.
Yeah, right there is perfect.
So I'm going to try to see whether I can.
It keeps going to that direction.
I think this is the issue here, where just, and I get, this is a this is a steerable catheter, so let me see if I can steer it away from this. It's a little bit better.
So I guess, I mean, the problem here is that once you're subintimal, it's very difficult to enter that calcium cap again. And the PK, is there a possibility of coming subintimal from the top and then meeting a bit lower down? Because that piece of calcium looks pretty much quite a big piece of rock. You know?
Because I want to see where I am here. The wire is moving freely, but then you know that we've created a pretty big dissection plane. We'll see where we are. Looks like right here is where we're pretty close here. And I don't know if we're going to be able to pop in.
Yeah, there.
But so what we're going to do now, Stephen, is probably come from above. With Dr. Guja is going to start from above, and I'm going to keep working from below. This is not where we want to be. We know that. So this is, yeah, I think, well, let's go from above. Let's start from above and below. So we're going to come from above now with another wire.
And Mehdi, maybe you can give us some idea. And I mean, coming from above, do you often use coaxial systems in a tibial vessel, or what's your preference for support?
Yeah, you know, honestly, 90% of the time come antegrade.
Yeah.
I do think, because in order to do wire-based crossing, you know, you really need to have control over the wire. And when you're going through the iliacs, you lose a lot of that, in my opinion. So I come antegrade, and I typically bring a 5 French sheet. So I don't go higher than 5 usually for below the knee. So use a 555, you know, sheet, bring it to the popliteal proximal AT. And then I use a 018 CXI support catheter, which allows me to go 014, 018 exchangeably. And usually with that, I have enough support to get across in an antegrade fashion. If I don't, I go retrograde. So I usually set a limit of 10 minutes to try antegrade. If that doesn't work in 10, 15 minutes, then I go retrograde, and then I do all the things that we discussed.
Yeah, like I said, interestingly, we do use probably exactly the same things. One thing that I found pretty useful, especially for anterior tibial lesions, is in addition to an antegrade and a long popliteal sheath, I would put a 4 French catheter into the anterior artery to take that bend, and then coaxial CXI and whatever wire across it. And often I do find that for very calcified lesions, you really need a lot of pushability and support. You know, so instead of putting the 5 French sheet into the tibial vessel, they use a 4 French diagnostic and then have that coaxial. You know. So,
yeah, that makes a lot of sense. You know, to have another layer of support.
Yeah.
Absolutely.
Yeah. So PK.
You can see here we're coming from above and below.
Can I have the slate monitors,
And
please?
you can see that the anterior tibial takeoff is there, and my wire is definitely off from below. So I'm going to pull this back even further and try to redirect as Dr. Guja comes from above. Part of the issues here is the torqueability of some of these wires are not as good as Mehdi said. You know, we have these tougher wires and tougher arches that just don't make sense. Can you go with a better wire from up top, please?
Yeah.
Thank you. And so what we're going to do is we're going to keep trying. And tell me if you guys are at this position where you get the wires to meet, which I think we will. Do you guys do cart? What do you do? I mean, what's your re-entry techniques at this stage from here?
You know, I tell you, you know, this is Mehdi, PK. You know, so you know, I think, you know, coming from the antegrade is helpful. You know, usually in the tibials, just the wires themselves create channels, and you're able to get through. If I don't get through, then I do exactly what you said. You know, I bring a 2530 balloon and try to inflate either in a retrograde or an antegrade fashion, so cart or reverse cart, and try to see if we can find a channel. But somehow the tibials are different than the POP and the SFA. You get lucky, and I think just the wires themselves find some channels for us, usually. At least that's my experience, I don't know.
And I think over here, we're just going to come from above, which I think is going to help, you know. So we're going to go with a coronary wire from above. And I'm going to try to keep redirecting from below. I keep thinking I'm in the wrong area here. So let me try to find another plane and see whether we get a little bit closer.
So PK, we're going to give you a little bit of time to work on this piece of rock, and then meanwhile we'll have Mehdi give a talk, and then either come back to you or to Leipzig. Is that okay, PK?
That sounds great.
PK, can you hear us?
Yeah. So
you seem to have done some work. Tell us what you have.
So I got to tell you, you know, the inspiration from Mehdi there to try to do both sides worked. So what happened was we came from above, and I'm going to show you in a second as he goes up with the balloon. We came from above with a wire, and then we were able to just dot the cap from above and create a little bit of a channel. So with that little channel, we were able to pop actually the wire that crossed was the command wire, and the command just popped up through this. So then after we popped up through this, I'll show you, we externalized the wire, we changed
Sure,
out
you can show
for
it.
a safer wire. Not that command's not safe, I just don't like
Offload,
hydrophilic wires when we're working, when we can't see the tip of the wire. So we switched out to our Sparticle wire, and you can see here with the dottering that Dr. Guja did, we were able to pop right in from below. And then we were able to put the 018 Cook balloon, the 3.0 balloon from below through the sheath. And now we're balloon angioplasting. Flora? So now what I'm going to do is just balloon the whole thing. I'm going to keep the balloon in my sheath, which is going to allow me to, God forbid, if I have 2 subintimal and perf, deal with that. And I think that's a very good, important thing. Go up here, guys. So I think what's important is here you can see we're subintimal.
25.
And as you can see, this is going to be the issue where I'm scared about what can possibly happen. So we are now aggressively ballooning, and we do have Jomed coverage stents if we need to. But here you can see here, the balloon angioplasty is occurring at the 3.0 level. Down. So now I'm going to pull back a little bit more because I know the lesion is also a little bit lower than this. Right there. Go up again, please. And at this level, we'll do. Then what I'm going to do is also do prolonged balloon angioplasty. This is just to make my channel with a 3.0 balloon. He's feeling this, as you can imagine, because of the. Oh, I'm sorry, sir. Because of the stretch of the vessel.
Relax. It's just a, it's
Stephen,
just a
how do you
closed
size
vessel.
your
We are trying to
vessels below
open
the
the
knee?
vessel. Okay.
Me personally, I tend to oversize the balloon. Well, I shouldn't say oversize, aggressively size the balloon. I do find that in the context of a subintimal recanalization and basically you're expanding the area that's outside the concentric calcium in the adventitial area. I do find that recoil is quite significant. So I would actually use a 3 mil balloon in some of our Asian patients quite routinely. My strategy of balloon angioplasty has changed over the years. I tend to use non-compliant balloons below the knee rather than semi-compliant balloons. I think they get a better result in my opinion.
Mehdi, what do you do?
I don't know. I don't have any data to back this up. At least if there is data, I don't know where it is. If somebody knows, it'd be great. But I like to gradually go up. You know, I start with a 2.5. I definitely agree that we need to aggressively size, that these arteries, we know they recoil. We know that they are bigger than what we think. So definitely treating tibial vessels with a 2.5 balloon is a mistake and is wrong, in my opinion, in majority, if not all the patients. So usually 3.0 to 3.5, depending on the location. But I like to start with a 2.5, especially in a situation like this, when you're not sure, you're worried about perforation, and then gradually work your way up to 3.0 and 3.5 as needed. Or maybe even use a tapered balloon, use the 3.0, 2.5 tapered balloon, depending on the length of the lesion and those kind of things.
I think that's great advice, Mehdi. So you can see here now, he was moving. Again, he has a very painful ulcer. You can see the flow is there, distal. We're now able to, and we preserve the collateral. So in my opinion, in this kind of crossing with this kind of calcium, I think I have to stent. I don't know what you guys think. I've already decided to stent this.
It's one vessel.
So with this single vessel, with obviously a Rutherford high-grade lesion that's not been healing, I'm going to go ahead and put a Zions. I know it's off-label. This is their new Zions Sierra. What we've noticed about this, watch your hands, please. What we've noticed about this is that we're able to track this through this Cook pedal sheath, which is a 3.9. So this is not something that's recommended. I want to be full disclosure with the company that this is not something that's recommended through them. It's just something that we do as taking care of our patients. So you can see here Dr. Guja is advancing the stent. And we did this obviously in a dry model first. We deployed and inflated the stent. So we did all that. So
from above.
now the stent is going, and he's got to go higher.
I know.
You got to go across the calcium. Right, a little higher, please. I'll show you where you're going to start. A little bit higher. A little bit higher. A little bit higher. A little bit higher. All right, I like that. Let's start maybe a little higher than that.
Yeah.
Let's start there. So are you worried about compression in this zone? I'm just curious what everybody thinks. He's not extremely young, but he's an active guy. In this area, are you worried about stent crush?
Personally, in the tibial stents I've put below the knee, I don't tend to see any compression at this area.
Exactly.
And in some of the dynamics, in the context of another trial, having to look at stents put into veins, doing on CT and MR, there doesn't seem to be any significant compression.
18, 20.
PK, I think I'm afraid we're going to have to leave you pretty soon, and we probably have to look at the results. And I think this is a great demonstration of tibial recanalization through a combined antegrade retrograde approach, and the fact that you're putting in stents, which is a testament to the limitation of the current resources we have to treat the tibial vessels. So we're going to try and come back to you a little bit later on, but I'd like to congratulate you on a successful recanalization of the vessel.
So I just want to show you the last picture here after the stent. You can see here we have great flow. And I think this is the first time that you could show that you can actually do stenting through the pedal access.
2.4.
So now we're going to finish up, and I will show you the final picture later. Thank you for all the great advice, and we'll see you back soon. Thank you.
Thank you, PK.
Thank you,
Great job.
PK. Thank
Great
you.
job.